Hi, everybody. Welcome to the very first episode of the Perfusion Perspective. My name's Donnie. If you don't already know, I'm a cardiovascular perfusion student at Emory University in the United States, and I'm making this podcast to basically teach all of you perfusion students, pre-perfusion students, anyone who's interested about this amazing field, the basic stuff that you should know before getting into it, while you're in school, while you're doing your clinicals, all sorts of stuff like that. So that's the mission of this podcast here. But today we're going to be talking about the basics of cardiovascular perfusion. What is it? How do you become a perfusionist? What are some common misconceptions about being a perfusionist? All sorts of stuff right up that alley. So if you're interested in learning about the most amazing career in all of healthcare, extremely unknown, amazing career, stick around. All right, so first topic we're going to get into today. What is cardiovascular perfusion? Now, if you're watching this, you've probably heard of it before, but if you're not, we're going to do a basic, very low-level explanation of the job. We will go into it further and explain it more in depth as this series goes on, as this podcast begins to grow. But for now, we're just going to talk a little bit about the basics of it and what the basic role, what I tell people when people ask. And if you're considering going into perfusion, I highly suggest that you learn how to explain it yourself, because every single person you meet, you're going to have to explain it to them, unless they work in some sort of cardiac setting or cardiac OR or ICU or something like that. But essentially what I tell people is work in cardiac surgery. Now, when they're doing cardiac surgery, the surgeon's going to open up the chest, work on the heart, open up the heart most of the time to repair some sort of valve, vessel, something like that. Now, the heart's beating all the time. Every second it's a beat most of the time for most people. Every single second it's beating, it's pumping blood throughout your entire body, and it's filled with blood nearly all the time. So how in the world is a surgeon supposed to open up a heart when it's beating, moving around, and just filled with blood? That is where a perfusionist comes in. Now, we have a machine called the heart-lung machine. We hook that machine up to the heart, and it replaces the function of the heart and the lungs. So we stop the heart, we drain the blood out of the heart so the heart is completely empty and motionless, and all of that blood that should be in the heart goes to this machine. And we have a bunch of knobs, a bunch of settings, a bunch of numbers to manage on this machine to basically take over the role of the heart and the lungs while the heart stopped, so that the surgeon can work on it. And then once that heart is fully repaired and once the surgery is over, we will bring that function back. We will transition the function of the heart and the lungs from this heart-lung machine back to the patient. So that's essentially what it is in very broad terms. All you really have to know is, if you're getting a basic level of understanding, is we replace the function of the heart and the lungs while the heart stopped during heart and lung surgery. So we know we replace the roles of the heart and the lungs during cardiac surgery. But what does a day in the life look like for a perfusionist? So a perfusionist starts every single day. This may be done the day before or the night before, but your first thing is building and priming a pump or a heart-lung machine. Most of the components of a circuit are disposable because they come in contact with a patient's blood every single case. So you're going to have to replace them and build them again and prime them up so that they're all ready for the next surgery. No matter what surgery it is, this is an essential. You need to do this before every single case you do. Now, after you build and prime the pump, the next thing you're going to do, and this is a non-negotiable for every single perfusionist in the entire country of the United States. I don't know how it is in other countries, but I know in the United States this is a rule that every perfusionist must follow, and that is preparation and checklists. So you're going to have to do a checklist before every single case. Every single case requires a safety check. So anything that can go wrong with the pump, it's going to be on this big either sheet of paper. It might be in your chart. If you do electronic charting, it might be on there. But it makes sure that every perfusionist double checks any of these components that are most likely to go wrong if not installed correctly, not primed correctly, if they're out of date or expired, stuff like that. So every perfusionist has to do that. Now, there are things that you can't control or that aren't on the checklist because they're extremely rare. You can't prevent every single thing from happening, but all of the general things that are extremely easy to avoid if done correctly and checked over are on this checklist, and that's done before every single case. Now, after you do your safety checklist and you prepare, look through the patient's history, review the procedure you're doing, all the standards and protocols for the procedure that you're doing, surgeon preferences, stuff like that, you're going to wait a little bit. That's something perfusionists always do. You hurry up and wait. But essentially afterwards, after you do this checklist, you're going to hook up the pump, or the surgeon rather is going to hook up the sterile part of your pump to the patient, and you're going to do something we refer to as initiate bypass, which is basically you are beginning the transition of the heart and the lung function from the patient to the machine. Now, it is a gradual process rather. It's not a snap of the finger type of thing. It doesn't go one to the next, one to the other in the snap of a finger. So it's a gradual process. It usually takes about a minute, 30 seconds to a minute to transition full support over, empty the heart out, and make sure that the heart isn't beating. So after initiating bypass, we use a solution called cardioplegia. Now, you might have heard of it before. You might have, I guess, if you're in the cardiac surgery world, but it's essentially a solution that contains an extremely high amount of potassium for the human body that's injected right into the heart. Now, we don't inject it like with a syringe. That's not how it's injected. We use our machine to kind of pump it right into the heart. And this high level of potassium in the machine, or in the solution rather, stops the heart completely. It goes from beating with a normal EKG or sometimes an irregular EKG or an arrhythmia to complete asystole or a complete flat line. So the heart is completely stopped. It's not doing anything. It's just laying there. It looks like it's essentially cardiac arrest. The heart has completely stopped, and that's when the procedure will begin. The official procedure will begin. The heart is stopped. And this, you redose. It doesn't last all case long. You have to redose intermittently throughout the case, but that's the next step. After you initiate bypass, you're going to stop the heart with cardioplegia. Now, after the heart is stopped, and I said already, the case can begin. After the case begins, you're kind of in the clear for a little bit. Your job now is to manage bypass. You've successfully transitioned support over to your machine. You're completely supporting this patient. Now it's your job to manage bypass. You're doing the job of the heart and the lungs. You're making sure that the blood is adequately oxygenated. You're controlling the flow or the circulation throughout the patient's body. You're controlling the temperature of the patient, and you're controlling things like hematocrit and pH and carbon dioxide and all sorts of variables and vitals, as well as blood pressure, stuff like that. So it's not, you're not out of the clear after you initiate bypass. That is definitely the more stressful, kind of anxiety-inducing part of the job, but you have a much simpler kind of, okay, we got here, we got it over with, the transition's over, time to manage, make sure all the vitals are looking good, the blood's in good shape. So you've been managing bypass, and now the case is coming to a close. The surgeon is completely done working on the heart. They've sewed it back up. They're essentially done working on the outside of the heart. The heart is in good condition. You're ready to transition that support from the heart and the lungs back to the patient. So how we do that, we termed it weaning from bypass. So essentially what you're going to do is gradually transition that support back over to the patient. This has to be done in a gradual manner. You can't just completely shut off the support and fill the heart up and just boom, all done right there. This is a very gradual process. You have to come down very incrementally on your flow. You have to make sure the pressure differential is not extremely high. You can't go from pushing 300 millimeters of mercury into the heart to just nothing. So you got to come down slowly and then ease its way back into the patient's complete functioning heart and lungs. Now, after you do that, after you wean from bypass and you come off, the patient has regained all of its cardiovascular and pulmonary functions, you're done, hopefully. There are situations, emergency situations, where you're not done. But in a normal, perfect case, you're done. You can start tearing down. Usually you start tearing down after the patient leaves, or after the patient has been closed up, just in case you have to go back on, in case the surgeon missed something or there's complications or something like that. But you take apart your pump and you'll probably rebuild it depending on your hospital's policy, your hospital's way of doing things. You'll tear it down, dispose of all of the contaminated material, and rebuild it back up. Now, that is basically a day in the life or a perfusionist perspective of a case. I slipped my podcast title in there. You see that? Anyway, yeah, enough with the jokes. So you're going to throw away all your stuff, rebuild it. You're all done. You've completed a surgery, a case as a perfusionist. Now, although it may seem simple the way I describe it, it is a very complicated job, and one of the most important things, other than the knowledge of what's going on and your manual dexterity, which you'll learn in school. You'll learn the physiology and the manual kind of dexterity and how to use the mechanical pump in school. Other than that stuff, one of the most important things during these cases is communication. You have to be able to communicate. Something I didn't say that goes on all case long is you're talking. You're talking to the surgeon. You're talking to the anesthesiologist. You're talking to the surgical assistant. You'll have to talk to the circulating nurse to maybe ask them for equipment, ask them about timing, all sorts of stuff like that, where they are in the case. If you don't have a camera in your operating room. So that's also extremely important. It's not I sit back here and I don't say anything. It's an extremely important part of the job to be able to communicate with your surgical team. All right, we're going to cover one more thing before the end of this video, and that's how you can become a perfusionist. So if you listen to that, now it might not sound extremely exciting or extremely awesome, kind of amazing job that it is when I describe it, but it's a fantastic job. And if you go to Shadow or you research it a little bit more, you look up some videos online on how it's actually done, you'll probably find that this is such an awesome career, and you'll think, I want to do this for the rest of my life. This sounds so freaking awesome. So I'm going to explain to you how to get that done, how to become a perfusionist. So first thing, you need a bachelor's degree. That's a 4-year degree from any college, any university in the United States that's like a real university, obviously. Now, it doesn't matter what your major is generally. You could major in biology, which is what I majored in. It's a very easy kind of major to get in all your prereqs. Now, prerequisite courses are the courses that you have to take to get into perfusion school. They are mandatory. It's classes like biology, chemistry, anatomy, and physiology. Sometimes you got to take math and like medical terminology, stuff like that, just so you have the background knowledge of, I know the stuff that they're going to expect me to know when I show up to my master's program or my perfusion program. So it doesn't really matter what your major is. You can major in psychology, you can major in engineering. I have a classmate who majored in business. You just have to take those prerequisite courses that I just mentioned. Now, I think it's a lot easier to major in something like biology or physiology or chemistry or something, because a lot of those courses are already kind of baked into the curriculum that you need to get that degree. You won't have to take extra classes like, say, a business major or an engineering major might have to take. So you finish your bachelor's degree and your prerequisite coursework. Now you apply to perfusion programs. Now there's a limited amount of perfusion programs in the United States. I believe there's somewhere in between 20 and 25 at the moment. There are starting to become more programs, but there's not a whole lot. It's a pretty selective process. So do well in your undergrad. And we will go over actually how to get into school, what you need to do in your undergrad, what kind of extracurriculars you need, what kind of GPA you need, all sorts of stuff like that in the very next video. So if you're interested in learning about what kind of stats you need, what kind of essay to write when they ask you to write an essay, interview, stuff like that, we will cover that in the very next episode. But after you get into your perfusion school, after you apply, you get in, you're going to have to start school. And generally that's 2 years. I believe my program's 22 months. Most programs range from 12 months to 24 months. Mine's 22. So you're going to do your first year, or the majority of your first year is going to be done in a didactic setting. At least that's how my school is. Schools differ on how they present their curriculum, how their curriculum goes. You can find usually all of these curriculums for the schools you're interested in on their websites. They'll tell you kind of what path they follow through school. But my school follows a more traditional path in which you will do about a year of didactic learning, which is book work. We still do observations, so we're in the OR a little bit, but we do book work. We learn all of the knowledge, the pathophysiology, the pharmacology, the perfusion technology, stuff like that. We learn all of that in the first year to prep us for the second half of the program, which is the clinical aspect, meaning you'll probably still have some classes. Sometimes you won't, depends on your school, but you're going to be in the hospital every single day. You're going to be pumping surgeries, pumping cases on real patients every single day. And it's really scary, but there's a preceptor there with you all the time, and you'll get graded on, I wouldn't say you get graded on your performance, but you get graded on your ability to learn how to translate your skills from your didactic portion and your simulation training during your didactic portion of your program to an actual operating room setting with a real patient, real surgeon, real staff, all sorts of stuff like that. A real setting. That's generally the second half of a program, or at least that's how my program is. Either way, you're going to be doing didactic and a clinical portion no matter what program you're going to. So after you finish this program, after you finish your clinical and didactic portions, you graduate. Very good, very happy, amazing time. You're done. Now you have to study for boards. You take 2 exams as part of the boards. Those are the PBSE, Perfusion Basic Science Exam, and the CAPE exam, which is the Clinical Applications in Perfusion exam. Now, you'll pump 40 cases as a graduated perfusionist. You'll be getting paid. You'll have a job. You'll probably, have someone with you for the first little bit because you're straight out of school. But you'll pump 40 cases, then you'll sit for those exams, and then you're done. You're done taking exams. You're done with schooling. You are a CCP, or a Certified Clinical Perfusionist, and the dream has come true. All right, everybody. This is the end of the episode. Thank you all so much for listening. If I lost you at all throughout the episode, there's going to be show notes in the bottom in the description. So if you want to look at those, do your own research, kind of look more into certain things that I talked about, it'll be down there. There's also going to be an email down there that you can email me directly questions if there's someone you'd like me to have on the podcast or an episode you'd like me to cover or a certain topic, inquiries, stuff like that. It'll be down below. That goes to me directly. You can ask me questions too. I'm perfectly fine answering all of your questions. I'll do my best to give you the most accurate response that I can. So if that's something you're interested in doing, go ahead and email me. My email is in the description. Thank you all so much for listening. I appreciate you all so much. I hope you all learned a lot. And that's all. Thank you.